have a lot of patients who come to me and they say, um, you know, doctor, I would never take
Mm,
chemotherapy. I'm
hmm.
willing to take an oral
Right.
medicine like
Right.
ADT and NHT or these hormone suppressive therapies. I wonder how you talk to your patients about, um, just kind of getting them through that concern about if
Hmm.
we are giving, whether it's urothelial or prostate, some
Hmm.
cytotoxic chemotherapy, and that difference, as well as I've heard you use some great words, Libby, when you explain to your patients that hormone therapy is being on treatment. It
Yeah.
is, life altering. So I
Hmm.
wonder if you can give us kind of any pearls of your wisdom when you're addressing both kind of hormone therapy as well as if you really think a patient would benefit from
Sure.
chemo.
So my approach is with the same advice that I would give, and it's approach with curiosity. To say, tell me, I can tell there's a lot of emotion around that phrase that you're putting a boundary around chemotherapy. Tell me about it. Why is that? Do you know someone who's gotten chemotherapy? Are you worried about specific things that could happen to your body or to you in a general way if you get chemotherapy? Are you worried about what it means for your health and what it means about the cancer if you're getting chemotherapy? I have found that patients usually have really specific reasons and they vary a great deal. So some patients have a lot of fear around side effects like again losing their hair or being nauseated and vomiting. That's a huge fear that's been extensively portrayed in the media, that people are going to be vomiting all the time, or that people will become really weak or bedbound. Patients are very fearful of that, and a lot of times they may know someone, and so sometimes it's a parent for again, one of our more mature adult patients, one of their parents may have had chemotherapy 30 years ago before we had, 5-HT3 antagonists like ondansetron to prevent chemo-induced nausea vomiting. So I find approaching with curiosity is what will enrich the conversation. More often than not, I am able to offer them authentic reassurance about what they're afraid of. Oh gosh, okay, so it sounds like someone was very sick when they were on that treatment. One thing that I can tell you is that I will never abandon you to manage these symptoms on your own. I will be here and we can make decisions to reduce the dose of treatment, to stop the treatment if we need to, and that you're not trapped doing a treatment that is not okay with you. So I find that that is usually what helps the conversation in a really meaningful way and also demonstrates that helps the patient feel heard and seen and helps build our rapport, relationship, and trust. So it also, again, generally works with relationships. I'm finding that now that I have a tween child, the approach with curiosity is a slam dunk there too, for now at least.
Love it. You're giving us pointers for all areas of life.
Yeah,
I
palliative
wonder,
care techniques really work on unsuspecting loved ones, I would say in general.
I like that. Um, I think maybe another area would love to have you speak to for physicians, myself included, is we'll see the reports from these large phase 3 clinical trials and all the efforts that have gone into patient reported outcomes.
Yes.
These questionnaires, they sometimes take, half an hour. Patients are filling out 2 or 3 of these questionnaires, and They do it before they start treatment. They do it during the course of the treatment. We're all
And
the time
beyond.
hounding them and
Hmm.
beyond.
Hmm.
And then, so I guess I would love to hear from your perspective, how do you sit down and look at that data?
Hmm.
Is it impactful to you and the treatment decisions that you make? And then how much of a direct conversation do you have about those outcomes? Do you
Hmm.
use those outcomes just to frame general side effect profile and, you know, um, or do you directly talk to the patient and
Hmm.
say, drug X improved, quality of life by, patient survey results or
Hmm.
something like this. So just curious to get your thoughts.
Sure. Well, I love getting in the weeds of those things, but I find that in reality, when I'm in front of a patient, that has never served me unless And I know this day has not come yet. It could. If I'm working with someone who's an expert in symptom science, yeah, we're going to talk about that questionnaire. But for most people, it's overwhelming to do that. And in some ways, it doesn't even feel fair because it feels like we're, sort of giving them data that we've barely digested. So my perspective is, I think when we're looking at cancer outcomes with a new regimen or comparing across regimens, I think the number one question is, what outcomes can this treatment accomplish? And number two question should be, at what cost will it accomplish those outcomes? And I think that I really see treatment side effects as a related but actually distinct concept from quality of life. And we see this because, one is global and almost existential. It's about role functioning. It's about meeting personal goals and, bucket list items and even just living life in a way that feels authentically good to the patient. That's global quality of life. And to some degree, it can look at symptoms more of a like a disease related quality of life too. But then adverse events are related, can contribute to quality of life, but are distinct. And so I try to keep them I when I talk to patients, I keep them as sort of related but distinct concepts. The way that I look at it is, again, to answer the question, at what cost did this treatment achieve these outcomes? So essentially, is the quality of life that patients can experience on this regimen better than, worse than, or the same as when they start the treatment? And compared to the, standard treatment or, the comparator arm historical, data in some fashion. So I think we're trying to figure out, you know, if this is going to achieve good disease control, delay progression-free survival, all of those sorts of things, then understanding what patients are going to be living with, what it will mean for their global kind of existential and their symptom burden. And I take that as something that I will summarize to patients if we have multiple options with similar efficacy, then I will paint them a picture about what the research shows about groups of patients on the treatment. So if I'm comparing, let's say, first line management for a patient with intermediate risk renal cell carcinoma, what I'm there are advantages and disadvantages to all the regimens. And so if I'm speaking about comparing two regimens, I might say, regimen A, we know that it looks like these two regimens have similar benefit to cancer control and how long people live. Option A will shrink the tumor faster. It will be a little bit more predictable because there's only one immune therapy medication and, and a few other things. And then, compare to another regimen, say this is less predictable. And then let's say I'm comparing a regimen that is known to have superior quality of life compared to the comparator arm in the trial, then I will say, and the group of people who got this treatment on the trial, they felt that their overall life was better than the people who got the other treatment. So I give it a very, very quick summary. And as I said, I talk very openly about symptom burden and how this is inevitable with any treatment, but I do share that as a snippet. And some patients will say, again, people often know their own mind. People will say, yeah, that sounds good, but I feel like my life's so good that if it gets a little bit worse, I can live with that. But what really matters to me? Shrinking the tumor. You're right. And people know that. They know that about themselves if you just, you know, try to make it a little bit more concrete.